Good afternoon, everyone. Thank you so much for joining us for our August UTASP and NCSD call. As you all know, today monkeypox is our topic and we have a packed agenda. So we're going to go ahead and get started now. Next slide, please. To start off the call, we're going to have a monkeypox situational update presented by Dr. Bryce Furness. Then we're going to hear from DC Health, presented by Sarah Gillani, and then New York City Department of Health, presented by Lucretia Jones and Nicole Burton. And then we know that there have been some pre-submitted questions, so we'll try to address those, as well as taking any questions that come up during the call through the chat, or if you'd like to come off mute at that time and have some group discussion. So before I turn it over for the situational update, we do have a 2-question poll that we can pull up now, if everyone could please answer. So the first question is your jurisdiction doing contact tracing for monkeypox? The response choices are yes, we are doing contact tracing for monkeypox. No, we were doing contact tracing for monkeypox, but stopped. No, we never did contact tracing for monkeypox, or not sure. And our second question is, what program in your jurisdiction is doing contact tracing for monkeypox? Is it HIV STD, communicable diseases, not sure, or contact tracing for monkeypox is not occurring in my jurisdiction? So I'll just give everyone a little bit of time to fill out the poll. And Talia, you can go ahead and let me know when you think we've kind of stopped receiving responses and end it. Okay. Thank you all for completing that poll. Here are the results. And now we're going to have another poll a little bit as we get into the call, but I'm going to turn it over to Dr. Furness for the situational update. And I'm going to share some slides right now.
Good morning and good afternoon, everybody. I apologize. The delay was my fault because I'm actually in exam room number 4 of the DC Health and Wellness Center, and this is a very old computer. So I am going to try and give a quick situational update on monkeypox, the 2022 response. Next slide. So what is currently happening? And I'm basically going to try and tell you what's currently happening in August of 2020.
Hold on just one second, Bryce. I'm just getting the slides up. Hold on 1 second.
Oh, no worries.
There are like so many things on my screen, I can't. Okay, you're good to go.
Okay, so if you just want to go to slide 3. What is monkeypox? And for those that don't know, it is an orthopox virus. It's in the same family as smallpox, but it typically causes a milder disease. It's formerly rare and just endemic in certain parts of West and Central Africa. There's 2 different clades or types. There's the West African type and there's the Central African type. And they actually differ quite a bit, especially when it comes to mortality. The Central African, the one that typically affects the Congo and those areas, that mortality can be 10%. The Western African clade or subtype tends to be less severe, and the mortality of that is associated with that is around 1%. We have seen a huge increase in monkeypox in non-endemic countries, and we have the 2022 global outbreak, which WHO declared an international emergency in July, and this spread in the current outbreak varies from past spreads, and I'll get to that in a minute. Next slide, please. So how does it spread? Monkeypox can spread to anyone through close personal, often skin-to-skin contact. That includes direct contact with a monkeypox rash, scabs, or body fluids from the person with monkeypox, touching objects or fabrics, which we call fomites, including bedding, towels, clothing, sheets, and surfaces that have been used by someone with monkeypox. Also contact with respiratory secretions, and we're talking about secretions, we're not talking about respiratory droplets. So these are big secretions. They're not really transmitted through breathing, but they are transmitted through kissing, talking closely, spittle, spit, those kind of things. And then there's also some evidence. There are animal vectors, and we're worried about an animal vector establishing itself in non-endemic countries like squirrels in the United States of America, which means it will be harder to get rid of this eventually. And there has been, I know one of the questions that was submitted beforehand had to do with pets. There is very good guidance on those with monkeypox in pets on CDC's website, but I will say that we've had the first documented case of human monkeypox that was transmitted to a dog, and that came out of France, and it was in Lancet last month. Next slide, please. So what are the symptoms of monkeypox? Monkeypox typically started with a flu-like symptoms like fever, lethargy, all the things you associate with COVID or with influenza. And then basically a rash typically developed. So you had this prodromal syndrome, and then you had a rash that could be confused with other rashes. Like, so the first case that we saw here in the clinic before it really showed up as the typical rash of monkeypox, we thought it was herpes. We've had a lot of co-infection with syphilis. So, you know, this can mimic other things. Later in its course, it tends to declare itself, and what I mean by that is they tend to be raised umbilicated lesions that are quite different than herpes or quite different from syphilis. The rash progresses to sores and blisters and scabs. In the current outbreak, the flu-like symptoms are missing or not mild. The first case we saw, the rash appeared 3 to 4 days before the flu-like symptoms, before the fever, before the lethargy, before the decrease in appetite. One thing that really marks this differently is that we're seeing rashes in atypical places like the genitals and rectal area, and these rashes tend to be really severe, very painful. We had a proctitis case, or we had a case in the butt of one patient, and he couldn't even sit down when we were doing his history and doing all the paperwork. And when he walked with his legs askew because his butt cheeks couldn't touch. It was so excruciating. Patients usually recover without treatment, but we are using a lot of treatment for these severe cases, especially the ones that involve the genitals and the rectum. Next slide, please. So this is Monkeypox Lesions 2022 clinical presentations, and I'm just going to say that we have seen every type of presentation you can imagine. We have seen the typical monkeypox photos from Africa with over 400 different lesions all over the body, including the face and the trunk and the arms. And we've seen that in HIV individuals, both those that have controlled HIV and those that don't. We've seen oral lesions. Like I mentioned, we've seen a lot of genital lesions. We've seen a lot of rectal lesions and proctitis, or really bad rectal symptoms, along with those lesions like bleeding and pain and sometimes discharge. Next slide, please. So this gives you the numbers. It's the monkeypox cases as of 8/23/22, which was yesterday. And there were almost 16,000 cases of monkeypox in the United States, and it's been reported in every single state, as well as several districts and islands and places, so Puerto Rico, Washington, D.C., places like that. While anyone can catch monkeypox, regardless of gender identity or sexual orientation, many of those affected in this particular outbreak are gay, bisexual, or other men who have sex with men. You know, this outbreak first became evident in Europe. There were a lot of cases in the United Kingdom. It was typically being diagnosed in STI clinics, and it was typically among GB and other MSM. And we're seeing that same pattern here in the United States of America. There have been cases among women, and there have been cases among children. So it can be spread in non-sexual situations. Next slide, please. So the testing for monkeypox that we're doing right now is actually, you have to take, they have to be symptomatic, and you have to take a swab, a very vigorous swab of the lesions, basically. You take 2 swabs per each lesion or per anatomical site. 1 swab was going to the local public health lab, 1 was going to CDC. So it's tested for orthopox at the local lab, and if that's positive, it's sent to CDC for monkeypox confirmation. People with suspected monkeypox should wear a mask and remind the provider when they're being tested that it could be monkeypox. I will say there are studies, and one's going on here in DC, where they're looking at whether or not oral swabs, throat swabs, and butt swabs can be used for diagnosis among patients who don't have a rash that can be swabbed. Next slide, please. Treatment for monkeypox. So I just want to be very clear, there are no FDA-approved treatments specifically for monkeypox. FDA has approved tecovirimat, which is a smallpox drug, to treat monkeypox during an outbreak or in certain situations. And we are using that to treat serious cases of monkeypox now. Other drugs, possibly useful but not tested, are listed there. So in this particular outbreak, we are using the tecovirimat, the TPOX. It was, there are a lot of barriers to getting that, paperwork, ordering it, all that kind of stuff. But at least anecdotally among the patients that I've used it on, it seems to improve the symptoms within the first 24 to 48 hours significantly. Next slide, please. So vaccination for monkeypox, I'm going to try and go through this quickly. There is post-exposure prophylaxis. So these are individuals that are identified through contact tracing that have been exposed to a confirmed case of monkeypox, and they're brought in for the Jynneos vaccine to prevent them actually getting the monkeypox disease. So that's post-exposure prophylaxis. A lot of you are probably familiar with the PEP++ clinics. And that's basically clinics that are run for people who have met high-risk criteria. And those high-risk criteria vary from place to place. A lot of places it's 2 or more sex partners in the last 14 days, or having anonymous sex partners, or having sex in group settings, or in sex venues. It varies from place to place. Washington, D.C.'s PEP++ criteria now includes both genders. We're especially worried about college students coming back. We're a small city within a 20-mile radius. We have 5 major universities, so we're worried that this is going to move out of the sexual and gender minority population into other populations when students come back onto campus this fall. So in DC right now, you meet the criteria for PEP++ if you're any gender, any age. They're also really pushing in DC for sex workers, not only those that engage in transactional sex, but employees that work in bathhouses or sex clubs, or employees that go into those venues to do STI screening. So that's vaccination. I'll mention there's an ACAM 2000 vaccine. It's not a very good vaccine in that there are a lot of side effects. It's not very popular, and it doesn't seem to have gotten any traction or any movement in this particular outbreak. ACAM 2000 cannot be used in HIV-positive individuals. Next slide, please. So this basically just goes through what I just mentioned. It mentions PEP and PEP++. You're going to get these slides, so you'll actually have this. Next slide, please. So what is CDC doing? We're doing a lot. We are informing the public about monkeypox. We're providing guidance to healthcare providers, health departments. We're reaching out to anyone, any of the stakeholders we think are involved in this. We are constantly updating information on CDC's website. We're supporting diagnostic testing. We're working closely with our state and local partners to raise awareness within the LGBTQ+ community. And we're also trying to walk that fine line by not providing anything to the general population that can be used for stigmatization. We're seeking public health partners and feedback. We're doing a lot of listening sessions to try and hear what's going on, similar to this with a lot of different organizations. Next slide, please. So dating apps, social media influence, and listening sessions, some of the things I just talked about, but we're working closely with Building Healthy Online Communities, or BHOC, to develop messages for dating apps where a lot of these guys are meeting each other or organizing events in sex clubs or bathhouses. We are using existing relationships with influencers to reach priority populations. And I don't know if you all saw, but Shea Coulee, who's one of the RuPaul All-Star winners, I believe, placed something on her Instagram or one of her social media platforms with links to CDC's website. So we instantly got traction with millions of people who didn't have to directly come to the CDC website. They actually just went to her profile or her social media and clicked on the link. We're also holding a lot of listening sessions with LGBTQ+ organizations like I previously mentioned. Next slide, please. I'm almost done, folks. So these are some resources for health departments and DIS. I'm not going to go through them. You'll get these slides, but all those links are live, and a lot of this stuff is on CD's website. So those are for health department and DIS resources. The next one are community resources. There's a lot of things on there, and again, we're constantly updating these, and you'll get these slides. Next slide, please. And then the key messages, we're really trying to push a harm reduction, sex positive approach. So get informed, get vaccinated, get talking. This is something that we as a community and our community really needs to address as best we can. And we obviously, as you all know, need to be the best advocates we can for ourselves and for others in our community. So last slide, please. That's just my information, and I'll be on the call for the rest of the call for questions and answers. I did want to talk a little bit about, I know there's a lot of concern out there about the difference between who's doing the contact tracing for monkeypox. There's some communicable diseases that are places that are doing it, and then there are also some programs where STD, HIV folks are doing it. I will say that here in DC, it's our communicable diseases folks, and they're doing an amazing job. And there are several things that we've set up to make, to set them up for success. One of those things is that I meet with all 4 of the EPIs in communicable diseases that are working on monkeypox. I meet with them weekly. We also embedded 2 of our best DIS from the STD HIV tuberculosis program in with them. So they're there for hands-on mentoring, side by side, working together, all that kind of stuff. And then the last thing is we've actually had some of the communicable disease individuals embed here at the DC Health and Wellness Center in the publicly funded STI clinic. And I know Sarah, who's going to talk to you now, she was here last Wednesday, a week ago today, and she actually did her first monkeypox interview face-to-face and thought that it went really well and is hoping that she can do more that way. So I'm going to stop and let others talk, and I think Sarah's next.
Thank you so much. That was great. I will now turn it over to Sarah, and Sarah, feel free to share your screen if you need to.
Hi there. Thank you so much. So my name is Sarah, and I'm an epidemiologist with DC Health. Like Bryce mentioned, I work with communicable diseases for the Center for Policy Planning and Evaluation here in the Outbreak Investigation Team. So I'd like to talk to you all today a little bit about our investigations and how we've utilized technology to help connect the dots. So pre-investigation and during investigation with our cases, we try to collect as much information about sexual partners and contacts as possible. So we collect, and this is all standard stuff. So names, their nicknames, drag names, aliases, phone number, an address for an encounter or their location if they have it, the date of the encounter, age, gender, physical description, relationship, recent travel, and or any other notes that we can use to try to find more information on these individuals. Particularly in this outbreak, we've encountered a lot of situations where our cases might have had sexual contact with an individual who they're unable to name or they have very limited information for. But just like I mentioned, we try to collect as much information as we can and then use that information to try to, in collaboration with information that we've collected from other interviews and by utilizing technology to really connect the dots and get a better picture and ultimately be able to reach out to these contacts. To inform them of their exposure, talk to them about symptom monitoring, and offer them a vaccine and any resources that they may need to stay healthy and safe. So in some of our investigations, the use of technology has really been critical in being able to identify contacts. So I have a few case studies that I'd like to talk about. So there was an event that we learned about at a bathhouse where there was about 100 people, both from within the US and from outside of the US. And we had a case that was present that reported having unprotected sex with about 5 or 6 individuals while they were presenting genital lesions. So we definitely wanted to ensure that we were able to reach out again, because it would have been to inform these contacts of their potential exposures. In this particular situation, timeliness was of the essence, because by the time the individual had tested positive and fell into our hands, there had been a fair amount of time that had passed. Of course, we reached out to the venue and the organization that had hosted the event. But again, timeliness was a factor here. So we connected with the the individual who had become sick and tried to better understand who some of these people could have been. What we learned from this investigation is that this event was really active on social media, particularly Twitter, and the individual was able to find social media handles, so Twitter handles, for some of the individuals, but was unable to provide additional contact information. So what we ended up doing was we created a Twitter account, and we reached out to some of these individuals that were within our jurisdiction. And of course, we sent the other individuals to the appropriate jurisdictions, and were able to conduct outreach. And notify the contacts of their exposure, and again, connect them with the resources that they may need. We were very successful in this, and we were able to identify all 5 of the individuals. Again, unclear at this time if there was a 6th individual, but we were able to identify 5 of them. And in terms of I can share my screen, bear with me one sec. I've become so accustomed to Teams.
Sarah, it's at the bottom of your screen. There's a green share screen button. Do you see that?
I do see it, but there are basic, advanced, and then files. It's okay. In terms of what I had to share, it was just a screenshot of a message with of like the profile. So essentially we created a profile on Twitter, and the Twitter handle was very simple, just Sarah from DC Health. And in terms of the message, it was, again, very simple. Hello, this is Sarah from DC Health, and I would like to speak to you. Please call me at, and then the phone number at your earliest availability. Sometimes we get responses from our contacts that are both that can be where they express their hesitancy, of course, because it's over social media. So we always make sure to address those concerns based off what they said. In the example that I had, the person had written back, "Is this for real?" So we apologize for reaching out over Twitter and provided our DC Health information, so the email and a phone number, and worked with them to verify our identity. So that was a very successful methodology that we had used for that particular event. And we were able to create linkages that way. And of course, reach out to our contacts. Another high-risk event that we had utilized social media or technology for was for a sex party that we became aware of. There was an individual who had been positive that had a sex party with about 12 individuals. And we were able to collect information for most of the individuals, but there were 1 or 2 people that we were unable to collect information for because all we had was their Scruff username. So thankfully we were able to find that, and through their Scruff username, we were able to look them up on Scruff because Scruff has a search option that's for free. So we searched their username and we were able to find them. In this instance, their Scruff username had, their profile had been linked to Instagram, and their Instagram had their first and last name. So we were able to reach out to them via their cell phone because we had their cell phone number on file. For this particular event, it was critical that we were able to identify all of the individuals because it was a high transmission event. Of the 12 people that were present, 6 of them ended up testing positive. So you might think, oh, it's just one person, but it was very important that we identified this one person. Unfortunately, by the time we were able to connect with this one person, they had been symptomatic, but they were symptomatic very early on. So we were able to get them interviewed very quickly and reach out to their contacts and helped reduce further transmission because they didn't even realize that that was a monkeypox like bump. Another situation that I thought was interesting that we encountered was two cases that had reported similar exposures. So somebody with the same name, similar descriptions. For one of the cases, they had the person's phone number, but they did, and then the other case had only had their Snapchat username. We were inclined to say that they were the same person, but with the information that we had, it was unclear still because we did not have enough matching information. It was very, very similar, but not exactly correct. What we ended up doing is we saved the phone number. So how Snapchat is often associated to cell phone numbers. So you're able to add friends through a phone number. So what we did is we saved the phone number in a phone and then looked in Snapchat to see if the username matched up. And we were able to find out that they did not match up. So we were able to determine that they were two separate potential exposures, which was interesting as well. Another tool that we sometimes utilize is called Socialcatfish.com. Essentially what it is a tool to find additional information from a person with limited information. So for example, an Instagram username or a Twitter handle, those sorts of things. We try using this, we like utilizing this because if we can find a name, we can use that name to find a phone number, because whenever possible, we prefer to reach out to people via cell phone and then use social media as a secondary option if there's no phone number available. So that tool has been also instrumental in being able to connect and identify with people, to identify and connect with people. That is all that I have on my end. Thank you all for letting me speak.
Thank you so much, Sarah. Now I will turn it over to New York City, and then we can do questions at the end. And Sarah, there are some questions in the chat. Maybe if you're able to answer some of those, and then the remainder we can do at the end. Thank you.
Good afternoon, everyone. My name is Lucretia Jones. I'm with the New York City Department of Health in the Bureau of Communicable Disease. And I have Nicole. Would you like to introduce yourself?
Hi, I'm Nicole Burton. I'm also from the New York City Department of Health and Mental Hygiene, and excited to talk to you all today.
Okay. All right, so I'm going to quickly review a little background on the Department of Health, how we're doing our monkeypox investigations and contact tracing, share a little of our data, talk about things that worked well, our challenges, and lessons learned. Okay, so this is just a slide just to let you see how big a health department we are. We are one of the largest in the world, serve over 8 million New Yorkers, and have over 6,000 staff employed throughout our 5 boroughs. Next. And so I'm glad I added this a little bit about communicable disease, because in New York City, Communicable is the lead on monkeypox. So in the Bureau, I am the director of the General Surveillance Unit. So I oversee the staff of public health EPIs and nurses that conduct investigations routinely on about 37 of our 75 reportable diseases. And our staff are very well trained and have been working through activations, you know, on all from COVID to Ebola and everything else. They do this work, the routine investigations, as well as routine, you know, do outbreak investigations. Next. So usually what happens when something new, we have a new outbreak, it starts in Communicable. Our staff, I have about 25 staff that report to me in the General Surveillance Unit. We usually start the outbreak investigation when it's more cases than we can handle. We do like a semi-activation. So in our division is also the bureaus of HIV, STI, immunizations, hepatitis. So we immediately pull staff from all of those bureaus to work with us in Communicable on the outbreak. When it gets larger than that, like with COVID, then we pull staff from throughout the Department of Health. And when it's very big, then we go into a citywide activation and pull in more staff. Next.
All right. I'm going to talk to everyone about monkeypox investigation and contact tracing. So the Surveillance and Epidemiology branch was tasked with the following activities: performing surveillance and epidemiological investigations, including contact tracing, coordinating specimens for lab testing, providing guidance to healthcare partners, providing timely and accurate information to DOHMH leadership and City Hall. So this presentation will focus on contact tracing. Contact tracing is a disease control measure used as a strategy for preventing its spread. During this process, identified cases are interviewed in order to elicit persons whom they may have had contact with who are at risk for contracting monkeypox. Upon elicitation, these persons are contacted, interviewed, assessed for risk, and referred for post-exposure prophylaxis or PEP if necessary. The New York City Department of Health and Mental Hygiene's Surveillance and Epidemiology Response Group's Surveillance and Investigations Unit are conducting monkeypox case investigations, contact elicitation, and contact tracing activities. In order to do this, we needed a protocol to follow. There are 5 basic steps to our case investigation and contact tracing protocol. First, all positive or suspect monkeypox cases are reported to the Department of Health, either through mandatory laboratory or provider reporting. These cases are interviewed by investigators and their close contacts are elicited. These contacts are interviewed and referred to PEP if eligible. And contacts have their symptoms actively monitored for 21 days post-exposure. And anyone who becomes symptomatic during those 21 days are encouraged to test for monkeypox. There are 2 teams within the Surveillance and Investigations Unit, the Case Investigation Team and the Contact Investigation Team. The responsibilities of the Case Investigation Team are to receive all suspect and possible cases, interview those cases and elicit close contacts that occurred since symptom onset, and refer all of those contacts to the Contact Investigation Team. The responsibilities of the Contact Investigation Team are to receive all close contacts from the Case Investigation Team, interview those contacts and assess their level of risk, and to refer all eligible contacts for PEP, and actively monitor contact symptoms for 21 days post-exposure. Each team is comprised of assignment coordinators, supervisors, and investigation team members. The role of the coordinator is to assign cases to the team supervisors for assignment, review completed investigations, and support supervisors where needed. Supervisors are expected to assign cases or contacts to their team members, perform a general review of assignments, and support their team members with investigations. Investigators conduct all case or contact interviews. If the investigators belong to the case investigation team, they're expected to notify the contact investigation team and provide isolation and quarantine guidance to the cases. If investigators belong to the contact investigation team, they provide symptom monitoring guidance and actively monitor cases for 21 days post-exposure and refer contacts to PEP as appropriate. This is a visual representation of the Surveillance and Investigations Unit structure. As you can see, there are 2 teams, the Case Investigation Team on the left and the Contact Investigation Team on the right. Assignment coordinators in blue assign out to the supervisors in bold, who in turn assign to the different members of their team. Case investigators interview cases using a set of interview questions that include basic demographics, employment history, medical history, exposures 21 days before illness onset, residence and household information, hospitalizations, and the elicitation of close contacts the case had since they started feeling sick. The current definition of a close contact that we use is those that are sexual, intimate, direct skin to skin, or being physically close to each other for a prolonged amount of time, such as less than 6 feet for 3 hours or more. These can include sexual partners, family, roommates, co-workers, or healthcare workers. All contacts must have occurred on or after symptom onset date. Elicitation of close contacts include the name, contact information, and gender of the close contact. Investigators are also asked to collect the date of last contact, which should be on or after the date of symptom onset, the relationship of the contact to the case, and the type of contact. For each close contact, cases are asked if the contact investigation team is allowed to share their name during the interview with the contact. Contact investigators interview the contacts using a set of interview questions as well. However, part of their responsibilities include assessing the contact's risk and referring those who are eligible for post-exposure prophylaxis or PEP.
Okay, so things that worked well. Okay, you can, next. All right, so one of the things that we got great data. I mean, we have a great team. We had today 2,810 cases in New York City, and we are able to assign an interview or attempt to interview every case that we receive. Of course, we do have trouble sometimes locating and getting back to cases, but we are able to attempt calls to each. Of those 2,810, we have identified 1,154 contacts that were named. Some, when we're not getting enough information, names because they were anonymous sex partners, we're not able to reach out to them. Of those that are contacts, we did refer 722 for active monitoring. Some were already past the point that no longer needed active monitoring. Of all our contacts received, we referred 492 for PEP. So in New York City, we were collaborating with our health and hospitals, so our private hospitals. So we had 2 sites that we were able to, when we got a eligible contact, we were able to refer them to get PEP, which was much easier for them because the lines and trying to get an appointment was very difficult, as everyone knows. And of those, 346 to date actually received PEP from our, through our H&H sites for our referrals, not from the clinics, our city clinics that, you know, also set up vaccination. Next. Okay, so this is just a little data we're able to share. Unfortunately, this is only up to last week, August 18th. So just, you know, of all the cases, we have 97% identify as male. Predominant age range, you see, are the 25 to 34-year-olds. I think we had about 13%. No, we had 6% in people under 25, and we had 13% in people 45 to 54. When we looked at race and ethnicity, we do ask for that, how people identify. And so people who identified as Hispanic, whether Hispanic, Black, or those Hispanic, was 31%. So that is the majority of our cases, followed by Black and white. So the Black here are Black non-Hispanic, as is white non-Hispanic. For sexual orientation, we have implemented in Communicable, we've had a data alignment task force. We've just instituted like 6 questions, race, ethnicity, and SOGI. We're asking for all our cases, whether monkeypox, COVID, and we've implemented that division-wide. And so of all the cases interviewed, 25% would not name a sexual orientation. So that data is missing. But of the 75 that did, 93% identify as LGBTQ and 7% as straight. And the rest of the data, the full data, is on our website that anyone can look at. Next. Also, things that worked well is that it was communicable disease that took the lead on it. Our staff, I mean, I can't say enough about the staff that worked there, the use of their experience. They were still working on COVID. And so also our surveillance and investigation unit. So when we activated, we have about 150 to 200 staff that report to us. And these are staff that have been working this outbreak. Some of them I've worked with from back when, after the World Trade and Anthrax investigation. So there's staff that know what we do and are trained. These staff, as I said, are coming from different programs, HIV, STI, so we have a very diverse group. Another thing that worked well is that we have hired 5 positions under the CDC DISEX. I know the New York City DOH, I think, received about 77 positions, and we were able to quickly hire and bring those staff on before, so they're working on monkeypox as well. Another thing that helps is because with our numbers, we've had to work evenings and weekends, and we're able to offer cash overtime to get people to work. And as I said before, we're having all the staff, we are able to attempt to interview all our cases and contacts.
So I'm going to report out on things that were challenging to us. At the beginning of the epidemic, we did not have enough staff at the beginning to keep up with all the new cases. Frequently, we would have cases left over at the end of every day that would just have to get done the next day. So we were a little behind at the beginning until we were able to onboard new staff members. A lot of programs were unwilling to allow staff to continue working with us after June 30th. June 30th is when we deactivated for COVID. Programs needed to resume their routine pre-COVID work and wanted their staff back to perform those duties. A lot of staff were burned out after 2.5 years of being activated and really did need a break. So that was a challenge that we had to address. There was a large volume of calls and a shortage of med epis. At the beginning, we didn't have a call center. So that created some challenges for us. There was a lot of frequent training and retraining that happened because the protocol kept changing. At the moment, we're on our 12th version of our case investigation form. So after every iteration, we do need to train staff. And communicating transmission risk to the public without stigmatizing was something that we needed to address as well. We did run into situations where people under investigation were refusing to name their contacts or didn't know their contact's name or phone number. This made it hard to perform contact tracing activities. Cases and contacts were often uninsured or without a regular provider, so we needed to link cases and contacts to a provider where they could receive care. Contacts were requesting testing, and we needed to address that as well. This is New York City. A lot of people live in close quarters. They share rooms or apartments with sometimes a lot of people. So we had to address isolation for cases who were unable to isolate, basically. We have to address the vaccine shortage and people naming non-close contacts. A lot of cases would name a lot of their friends or family members, people that they wanted to get the vaccine, but weren't actually a close contact. So we had to find ways to deal with that. And also we lost some pretty important leadership in the middle of our activation.
Okay, so just a few like lessons learned, things that we could do better. You know, prepare in advance to ensure we have adequate staffing. I guess in the beginning, we didn't think it would take off as quickly. We were pretty good because we had the extra staff, but that's one thing that health departments have to, you know, plan for. I think using this DISEX positions that most have received is essential to make sure you hire diverse staff, get them on and get them cross-trained. I said set up a process with hospitals to get electronic health record. This was not as important with monkeypox, but I just think that should be on everyone's radar. With COVID, it was essential. You know, being able to get records quickly without having to send staff out as we usually do. Preparing trainings, it's always good to have like some stock trainings, you know, to start up on a new activation, and things that are important, like just basic epi, you know, interpreting lab results and things that some staff, we notice, like when we pull staff from DOH outside of our Division of Disease Control, they really didn't have the epi background that was needed to like understand. So it's important to do that. Also set up a mechanism to rotate staff on and off, because our staff was just so burnt out from COVID to monkeypox, like the activations overlap. We were still doing COVID and started on monkeypox. So when we know like we have a slower day or a slower week, when I have, 20 teams, I will let some teams know that, okay, today you're not going to get any work so that you can, catch your breath and do it that way so that they're not all on edge waiting for the next few cases to be assigned. And meet regularly with your staff. I know we have so many meetings. I have too many, and sometimes it's with the leadership, but you got to remember the staff that are, on the ground doing this work, you need to keep them updated.
So in conclusion, with new and emerging infections increasingly becoming a threat to public health, we have to prepare and be ready for the next outbreak. As public health leaders, we must ensure that we have adequate and diverse staffing of cross-trained personnel who can quickly support any disease investigation that can arise. We must create tools in advance that may be needed for our disease investigation and intervention specialists that are comprehensive, flexible, and can be edited for the scenario and allow for swift scale up. We also need to ensure our technologies are up to date and handle the demand needed, and ensure that all staff not only receive training, but the technical support needed to do their work properly.
And this is just acknowledgement. It's such a great team, a big team, and I want to thank everyone in my staff that's on this call for all their great work and dedication. Thank you.
Thank you.
Thank you both so much. That was wonderful. I'm now going to turn it over to Rachel Kocher to kind of manage the question session. And if anyone wants to come off mute and ask a question or continue to ask, there's some questions I know in the chat. Please feel free.
Yes, please do come off mute if you would like to ask a question. And while we're potentially waiting for people to ask questions, I'll throw this out to both of or all the presenters. There was a question in the chat about whether jurisdictions are using their COVID-19 infrastructure for contact tracing for monkeypox, or if they're using some other existing solution.
Okay, well, I'll start. In New York City, we have our ICS set up. We have Nicole and I are co-leads of the surveillance unit. So we've used that, the same org chart, the same systems to set, and so it made it much easier. And for the staff, they just switched over. Okay, now instead of COVID, now we're learning, discussing monkeypox. So yes, we are using the same infrastructure in New York.
DC, did you want to answer that question as well?
Hi there. Here in DC, we are also utilizing staff that had worked on the COVID-19 response. They had just been cross-trained to work in monkeypox as well.
Okay, thank you. Tom Bertrand, I see that you're off mute. Do you want to ask your question?
Yeah, thanks, Rachel. Appreciate it. Great presentation. Admire the work of New York City. We need to follow you. I'm just curious, when you interviewed cases and say they had anonymous partners or might have been exposed in a setting that might have been with a lot of possible exposures, like a sex party or a bathhouse, how did you manage that?
That's a great question. And I really don't know what others have done. I mean, we gathered information. I know we had one case who, reported a party of over 100 where he himself engaged and had anonymous sex with over 50 people. And the staff updated and sent the information around. So I don't know if another unit of the health department, because we were just doing, surveillance and epi. So we had others that did, outreach and did, the vaccinations in the eye clinic. So I really can't say if any follow-up was done, from other groups.
Sure. Okay, thank you so much. Appreciate it.
Sarah, did you have anything to add to that?
Yeah, sure. In terms of that, we also engage with our community members and our community health leaders to check in with the facility if there had been a known positive case present and put out a notification that way. For one of the events that we had, we also put out an FEX notification to several jurisdictions because other states had been involved as well.
Great, thank you. There were some questions early on. I'm going to pass this over to you, Bryce, about covering lesions and if we have recommendations on like the best materials, gauze, Band-Aids, do they offer any protection, or what would you recommend?
Yeah, I don't know that we have a lot of evidence on that, but coming from the harm reduction, of course, we hope that, and ultimately we wish that people who were symptomatic would isolate at home. We know that's not feasible for a lot of different reasons. So the next best thing is to cover those lesions when you're out. Oftentimes clothing is enough if it's just genital or rectal lesions. If you do have lesions on your extremities or your face or places that could be exposed in short sleeve shorts or short sleeve shirts, bandages, gauze, all of that should work. And if you have lesions on your hands, your fingers, especially if you're going to use that hand to touch commonly touched surfaces, we would recommend gloves if possible. So I don't know that there's any study out there about the best materials for covering these lesions, but I know that we have recommended bandages and taping gauze over them.
Thank you. There are a couple questions about comorbidities, and I was hoping both DC and New York City could talk about how you're managing them, or if you're even managing them. And I would also encourage others to come off and share their experiences. It's something we're very curious about. I know we've heard from some clinics that they've just turned into monkeypox clinics, and they're hardly able to deal with their STDs. So I'm wondering, so yeah, the question is, how are you managing comorbidities?
I'll start this. This is Bryce, and at the DC Health and Wellness Center, we are a publicly funded STI clinic, and it has turned out that a lot of our cases of monkeypox are actually established clients, either PrEP patients or ART clinic patients, HIV positive patients that are in care. We have seen a lot of non-established clients that have been referred to us from other places, and we are routinely trying to do we're trying to screen everybody for sexually transmitted infections. I will say that the first case that we diagnosed here at the clinic was co-infected with chlamydia of the genitals, and when we've had several cases that were co-infected with syphilis. I tell everybody that will listen, because a lot of these sores are on the genitals. Part of the genital workup is an HSV culture, a swab sent for HSV, and we've done a lot of those, but in my experience here, none of those have been positive. But we have seen a lot of bacterial STIs like chlamydia, gonorrhea, and syphilis co-infections. And I will shut up now.
For New York City, I don't know if someone from our STI clinics are on and can speak about that, but we, do collect that information. We have seen with interviewing cases, we'll say, and find out they are co-infected, but we are not following up, and I don't even know what proportion of our cases are coming through now our STI clinics as opposed to the private providers.
Thank you. Any other jurisdictions want to share how they're managing?
This is Bryce again, and I'll just add that, we're not technically calling this a sexually transmitted infection because we don't have a lot of evidence that it's transmitted in ejaculate, pre-ejaculate, vaginal fluids, those types of things, but it is being sexually associated. So we are seeing sex leading to a lot of these cases, that intimate contact, the large secretions, skin-to-skin contact, those types of things. So these patients really should be screened for STIs at the same time they're being tested and managed for monkeypox.
Thanks, Bryce. I think we may have time for two more questions. One is about how programs are managing daily monitoring of contacts. They mentioned that daily calls is not sustainable. So what could maybe somebody elucidate on how they're managing daily monitoring for contact?
Nicole, would you like to address that? I know okay.
Sure. We have a daily red cap survey that with permission from the contacts, they will have a daily survey texted to them, and they respond to their symptoms with, they respond to that survey with any symptoms that they may have.
How is the response? Pretty good? What the response rate on those?
To be honest, I think it's pretty good. I have to double check the numbers before I could comment on the response rate though.
Okay.
Yeah, that we much easier and better than when we first started, we were trying to call, you know, every day, every other day, and that wasn't working well at all. It was too time consuming and yeah.
Okay, I think it's, sorry, Sarah, go ahead.
Oh, sure. Just to add in terms of DC, at this time, because we are a smaller jurisdiction, we also are unable to do daily phone calls for monitoring, but we, our investigators and contact tracers have cell phones. So we do text and check in with our cases and contacts and have an open door policy. So we ask that the cases and contacts reach out to us directly as well. And we're working with our technology team to set up survey force as well.
Thank you. And Talia and Ali, are we at time at 3 o'clock, or did we have an extended time for this?
I think technically 3 o'clock, but if folks can stay on and answer more questions, I am not opposed to that, but I want to respect everybody's time.
Okay.
I'm able to stay since I was responsible for it being late.
Okay. If obviously people have to drop off if they need to. I think one of the things, Bryce, that people had been asking about was risk for businesses that sell clothing and risk on public transportation. Can you speak to that?
Yeah, we don't know what that risk is. We didn't know what that was when COVID first started, and we don't know it with monkeypox because, again, this is a very typical manifestation. This isn't what we normally see, especially in the endemic countries. So we don't know. I would say that we do know that the virus can be transmitted through fomites or through things that come in contact with a virus that then somebody else comes into contact with after that. We know that that's more likely to happen with soft surfaces like seats, cushions, or clothing or towels or sheets than it is hard surfaces like doorknobs or the metal poles on public transportation. That being said, again, we really encourage if you have lesions that have been either diagnosed or suspected to be monkeypox that you cover those lesions because we really don't know the answer to this. But in general, we are not seeing transmission from these types of situations yet in this particular outbreak. Most of this has to do with, most of this transmission is very intimate contact, often sexual in nature, but definitely transmitted through the close skin-to-skin contact and possibly through the respiratory secretions as well. So it's hard to answer that because we don't know, but I would say that we do know that the virus can be transmitted that way, so I think you need to take the necessary precautions. So if you're talking about clothes that are coming from a secondhand store somewhere else, they should be washed. Normal laundering seems to take care of this virus whatsoever. And you may not want to be trying on clothes in a place where a lot of people could have tried on the same clothes before you. I think that's the best we can provide right now.
Okay, thank you. There's a question, I'm just going to read it. As vaccine uptake increases among named contacts, are you prioritizing named contacts for second dose of vaccine? Are you seeing any decrease in named contacts per case over time?
Sarah, do you want to, you and I have talked about this. Do you want to talk about that or mention that?
Sure. So in terms of named contacts, we do on our end set up vaccine appointments for those individuals. And they do receive the 2 doses of the vaccine. For other individuals receiving the vaccine through our PEP++ clinic, there is an online portal that they are able to sign up for the vaccine through.
And I'm just going to add to that I think that some of the DIS are using the post-exposure prophylaxis as an enticement for actually eliciting partners because they can be scheduled rather quickly for that first Jynneos dose. We're not doing the fractional doses for post-exposure prophylaxis yet, and they get scheduled and follow up. They get a second appointment scheduled and follow up, and it's not going to be canceled. A lot of the PEP++ clinics have canceled appointments because of supply. So I think some of the DIS are kind of using the ability to get the post-exposure prophylaxis at the DC Health and Wellness Center rather than the PET++ clinic as a leverage for partner elicitation.
New York, do you want to talk about how contacts and prioritizing vaccines?
No, I can't really say with the prioritizing, but I did want to say that we did notice here lately a decrease in the number of contacts being named and referred, and we, discussed like why this might be happening. It could be that now that we're this far into the outbreak that people are not having contact in the infectious period with others like they did in the beginning before word was really out, but we are seeing a decrease in numbers of contacts named.
Bryce, there's a question about incubation time.
Okay.
Can you talk about what the incubation time is?
So what we're seeing basically is that between exposure and infection to onset of symptoms varies significantly. It seems to be shorter for those that do actually have a prodromal syndrome or have the flu-like illness symptoms before the rash shows up. The first case we saw, he basically started to have the rash. That was the first symptom, and that was 4 days after his exposure at a sex party in New York City. I think the window is anywhere from like 3. I think it's very similar to some of the other STIs. I think it's 3 to 21 days, but we have been seeing some patients show up as, the earliest I can say off the top of my head has been 4 days, but it's usually about a week to 10 days afterwards.
Thank you. And there, Dane, you're not allowed to ask questions in the chat. There was also a question about the new Jynneos or Jynneos dosing. Can you speak to that at all, Bryce?
Yeah, I can't say a lot of this because I'm not that familiar with the science behind it. But from what I do know is that it's less of a dose, but it's put into a different space, and the whole process gives you the same immune response. So even though you're getting less of a dose, you're not getting less protection, and it's not new. I will say that. Intradermal dosing or intradermal application of vaccines has been going on. Salk studied it when he studied polio. So it's a very good place to get certain cells to respond to the antigens that are in vaccine in order to mount an immune response. So from what I've heard from clients and friends, the 3 things I want to address about the fractional dosing or the 1/5 dosing is that it is effective. It is as effective as the full subcutaneous dose. It is not new. This is not like mRNA vaccines or something new. This has been going on for a long time. As long as people have been studying vaccines and immunology, there has been intradermal dosing. And it seems, there was a lot of evidence out there that the subcutaneous injection led to a nodule that could be painful, and that nodule could be there for weeks. I'm hearing that there's less of that with the intradermal injection, so less of a concern, hopefully. So those are the 3 things I've been hearing quite a bit, are that they think that it's because the dose is smaller, it's less effective. I think that there are a lot of people thinking the intradermal application of the vaccine is new, and it's not. And then people who had the subcutaneous initially and had that painful nodule at the injection site were worried they were going to get the same thing on the forearm or the intradermal dosing. And there is a response. There is usually redness and induration, but it's not like what we were seeing with the subcutaneous. So that's what I can say about that.
And then Dane asked about the vaccine effectiveness and if we know anything about how long we believe the vaccine will provide protection.
So it's a good question. That was better studied with the subcutaneous administration than the intradermal. We know that the most robust response from subcutaneous is about 2 weeks after the second dose. So the subcutaneous dosing was day 0, and then the second dose was 28 days after, and then 2 weeks later is when you got the best protection, if you will. We know that it's similar with the intradermal. It's the same dosing regimen. It's day 0 and day 28. We haven't studied as well, but there is some evidence that there is a quicker response via the intradermal application than the subcutaneous. So you actually may have better protection sooner than 2 weeks after the second dose, but I can't say that for sure.
Okay, thank you. And actually, Talia reminded me, we actually have a poll about this. So if you'll put that up, Talia, and we can get people to answer about whether your jurisdiction has started intradermal Jynneos. And the answers are yes, we have started. Second answer is planning to start, but haven't yet because of supply issues. Third choice, planning to start, but haven't yet because of training issues. Fourth is planning to start, but haven't yet because of supply and training issues. And then the last choice is haven't started.
And while we're waiting for those polls, Sarah just texted me, and apparently in DC, it's very clear that the incubation has changed to 3 to 17 days. So that's the incubation period we're seeing with these cases here in DC is from 3 to 17 days. Thank you, Sarah.
Okay. And then Talia, do you want to, it looks like most people have started, so that's great to see. Talia, do you want to put up the next question? There was one last question we were going to ask you guys. And it's, is your jurisdiction using mobile apps like Grindr, Scruff, and Jack to do contact tracing for monkeypox? 4 answer choices, yes, no, but interested in learning more, and don't know. And actually, while people are answering, we're going to wrap up here in a second, but if you have additional questions, please drop them in the chat right now. There were also questions that were submitted ahead of time that we will respond to and send back out. And then if there's other sessions like this that you would find to be useful about other specific topics. I know this one was about contact tracing and technology, but I know that monkeypox is kind of taken over everyone's lives. We are happy to do more of these. Just let us know again, also in the chat, if you would be interested in more topics on monkeypox. Okay.
And I'll just say, if there are any questions that weren't answered or additional questions that come in, Rachel and I will make sure that they're answered and disseminated, the responses.
Yes. Thank you. All right. I think I'm going to pass it back to either Talia or Ali.
Well, thank you all so much for the great presentations, the discussion. As Rachel and Bryce said, we will get a response document with all the questions that were submitted in the chat that have not been answered out to everyone. And if there are any questions, feel free to reach out to us on the screen. And with that, I will go ahead and conclude the webinar. Thank you all.